Hello, this is Amjad Al-Mandilawi from Baghdad, Iraq, presenting the parallel wire technique for the treatment of CTO. The case is a 76-year-old male with a stable angina, has hypertension, and a smoker without diabetes mellitus. He has a good LV function, and cath showed 3-vessel disease. This is the right coronary artery in LIO projection, shows multiple lesions at the mid part with a distal critical lesion. For the left system, there is a critical lesion in the distal left circumflex, and the LID has a mid to distal total occlusion, which will be shown in the cranial view in a minute. So basically, the patient has 3-vessel disease. One of them is totally occluded. In almost all cases, when you have multiple vessel disease, start PCI to the vessel that has the total occlusion, or let's say with the most difficult vessel. This is because if you fail in that vessel, you can always send back the patient to surgery. In very rare cases, you may treat the non-CTO vessel when the cardiac team decided that the trial to the CTO vessel is futile, or when the support is needed to treat the CTO vessel. Bilateral injection is of utmost importance, especially when there is a faint or absent ipsilateral visualization. The best way to do that is to inject the donor vessel first, because it takes longer time to visualize the distal vessel. Once the distal cap is shown by retrograde injection, an antegrade puff is given, and this will delineate the length of the occlusion. Here we can see the occlusion is almost 20 mm in length. The cap looks tapered, and there are subtle branches both at the proximal and the distal caps. There are 4 techniques to deal with CTO: the antegrade wire escalation, the antegrade dissection and re-entry, retrograde wiring, retrograde dissection and re-entry. Most of the cases are usually dealt with by antegrade wire escalation. For the current case, we started with pilot 50 wire just to negotiate the lesion and understand it more, and to look if there is a microchannel that can be crossed easily. And in that case, a fielder wire might be a better option. You can see that retrograde injection is not useful at this stage because we are not yet close to the distal cap. The first wire was not useful in crossing the lesion, so it was left in place, and the miracle 6 wire was taken. It passed to the mid part. Further manipulation, we managed to pass to the distal cap, and here comes the importance of contralateral injection. It shows the wire to be in the extraluminal space. At this stage, one can use fancy equipments like dual lumen microcatheter or equipments for dissection and re-entry, which I believe that most of the cath lab lack. What we did, we kept the miracle wire in place and took a pilot 200 wire to negotiate another course. The pilot 200 was again not in the right position, so we kept it in place and pulled back the miracle wire and negotiated another course which seemed to be in the right place. Multiple projections are needed to make sure of the wire position. The procedure is basically antegrade wire escalation with more than one wire used at the same time. The aim is to go for intimal tracking. Why is it useful? The first wire may modify the anatomy, especially if there is some tortuosity in the vessel, so keep it in place. If the first wire is in the wrong direction, it will prevent the second wire taking the same direction. If the first wire is in the false channel, it will occlude that channel and prevent the second wire passing into it. Multiple wires can be taken. This is another case where there is a long segment of RCA CTO with the bridge collaterals. 3 wires were used to cross the lesion. Sometimes you do not need to escalate the wire. Just leave the wire in place and take another wire with the same property. And this is the result of this last case. Going back to the first case, once you are sure that you are intraluminal, you can push the wire further, dilate the lesion, and stent, and this is the final result. And now you can treat the other vessel. So the message is that parallel wire technique is a useful and maybe cheaper way for the integrate treatment of CTOs. And thank you.